Hello. We're going to get started in topical lectures in childhood psychopathology. This is a new course for me to teach, a little outside in some ways of my traditional areas of interest, but certainly something that I'm well-versed in discussing. So we're going to start this first lecture, be very brief, and just touch on some basic issues in starting off thinking about these issues in what we call childhood psychopathology. So I want to start off by thinking about defining disorders, and we're talking about infancy, childhood, and adolescence. So this is really a developmental psychopathology kind of course. So the central premise of developmental psychopathology is that we gain a better understanding of children's disorders when we think about these disorders within the context of normal development. So one of the things we have to consider is whether or not someone might be developing normally, but just at a different time frame. So if you think about height and sort of where a child might be in their normal development, a child like myself, I didn't finish growing until I was in college after I was 18 years old. I was 5'4" when I graduated from high school, and I finished my freshman year in college at 5'8". So outside these sort of normal developmental parameters, perhaps, but not necessarily disordered. So it's one of those things we always have to kind of consider where somebody is in their developmental timeline and whether or not their behavior is advanced or perhaps not advanced enough, but where are they sort of on that overall normal curve of development. So it's important to sort of know that there are different models of childhood and child development, and what's disordered in one place is not going to be disordered in another. It's all very different, and so a lot of this is also cultural. It's all contextualized, and so we can't take ourselves abroad and start thinking that children are developing abnormally because their developmental timelines are going to be very different from ours, because their culture is very different, and what's important and what's normal versus not normal is all based on subjective evaluation. And that's one of the most important things to understand about any discussion of what we call abnormal psychology is a lot of it's in the eye of the beholder. For the most part, we don't have diagnostic tools that allow us to say, yep, that person has bipolar disorder or that person has autism. We have to infer those based on the behavioral characteristics, and those behavioral characteristics are always taken in context. So with a few exceptions, we don't have genetic tests, we don't have biological tests to run, we don't have blood tests. We have to rely on behavior, and that can be difficult. So as we get into things this semester, we're going to talk about how contemporary theorists, researchers, clinicians all emphasize that a useful model of normal development requires a dynamic appreciation of children's strengths and weaknesses. And so all of this is flexible, and we have to understand that some children are going to exceed in one area and not in another. Some people will be great at math, terrible at English. Some people might have really good social skills, some people might not. Some people might be shy but have good social skills. It's just simply, we have to take the entire child, think about their context, think about their behavior, and think about all of this in a more holistic and very dynamic sense. So that gets us at what is normal. No answer to that question. What's normal to you is not going to be normal to me. What's normal to me is not going to be normal to you. And that's where when we talk about something being abnormal, certainly there are disordered behaviors. And oftentimes, and this is what I think is very important, the most frequently, a lot of disorders are couched in terms of safety of the individual, their social functioning. So, for example, a substance abuse disorder is defined by disruptions in the ability to maintain occupations, maintain relationships, etc. And so it really is, we're talking about disruptions in sort of being able to live a happy and normal life is a big part of that kind of diagnosis. So when we talk about something that's normal, we can first talk about statistical deviance. And this isn't deviance as in, ooh, that's a deviant, which is a weird word anyway, but just statistical deviance from the mean. So when we're talking about things, something that's an infrequency of an emotion or a thought or a cognition or a behavior. So people that display too much or too little might have a disorder, particularly at any sort of age-expected behavior. So, for example, we might be talking about something like affect, which is the outward sort of display of emotion. And somebody who has no outward display of emotion, we would probably consider that disordered, because people should be displaying and experiencing emotion. That's a normal part of our experience. But they might have too much emotion. That is, they might break down crying for no reason or for reasons that don't make sense, at least don't make sense to us. And so we can think about this in terms of where are they in the sort of normal curve. So when we talk about the normal curve a lot, of course, you all have some experience with that, where we have, a sort of median or average behavior, amount of behavior, sort of an average amount of emotion. 2 standard deviations away, people will have a lot of emotion but still not be abnormal. 2 standard deviations below, they might have very little emotion but still not be abnormal. When we get way out into the very disordered with no emotion, or complete inability to control emotions, that's when we start getting into statistically deviant behavior. Sociocultural norms, these are our beliefs and expectations of groups about what kinds of emotions, cognitions, and or behaviors are undesirable or unacceptable. And this is the Wild West in terms of thinking about what is normal. Because you can go from one part of the United States to another and still come across sort of different expectations about what's normal and what's abnormal. And certainly within cultures within a culture about what's normal and what's abnormal. All of these are based on values, they're based on religion, they're based on culture. So what's an acceptable emotion or thought or behavior in the Western world might not be so somewhere else. So for example, in the sort of Western world, we're fairly liberal about our views about sexual orientation, certainly compared to when I was growing up. We have a much more liberalized view of that. But other parts of the world, that's not the case. And that's what their social-cultural values are and what their norms are. It's easy for us to judge one culture versus another based on what our values are, but we also have to understand that those social-cultural norms exist, and we kind of have to respect them. I don't know. Different views on that. But we have to understand they're not ours, and that's the most important part of that. And so what somebody else's social culture beliefs are different from ours. They look at us much like we look at other people. Because we're so different, the best thing we can try to do is try to understand one another and understand those social cultural differences exist, and try not to impose ours on other people or let other people impose their values and views on us. This is a difficult needle to thread sometimes, but I think we should all do our best. So then we get into mental health definitions. This is where we're going to wander across all 3 of these throughout the semester. Mental health definitions. Here's where we start getting to do theoretical, clinical notions of distress and dysfunction, where we start getting into criteria-based diagnosis. Have to meet 1 or more of the following symptoms, 3 or more of the following symptoms, etc. And so we start thinking about clinically diagnosing individuals for treatment. Now, one of the important things about mental health definitions is, first of all, they're culturally based as well. They are part of the zeitgeist, and we're going to talk about that here in just a minute. They change over time. But they're also very important in our insane world of insurance reimbursement. So if a therapist is going to get paid, or a psychiatrist is going to get paid, or a mental health institution is going to get paid by Medicare, Medicaid, or private insurance, an individual has to have a diagnosis. And so trying to treat people with distress, we have to come up who are in distress, making sure they're getting treated well. We have to have some kind of diagnosis. There are a couple of different systems for that: the Diagnostic and Statistical Manual of Mental Disorders, or the DSM, and the ICD-9 or 10. I can't remember what number we're on at this point. I think we're transitioning to 10. Anyway, that is the sort of international classification, and it has a lot of different classifications for diagnoses. And some people find it weird. So, for example, homosexuality is still a diagnosis under the ICD-9, but that is important for individuals who are trying to get pre-exposure prophylaxis, or PrEP, which is an HIV prevention drug. And so that diagnosis code allows for that drug to be prescribed to an individual who's at greater risk for HIV. So the whole point of this is that these diagnostic codes and diagnostic tools have a number of different purposes. So now what do we do with children? This is particularly a negative quality of life is the most important diagnosis part of this. They're functioning poorly or exhibiting certain kinds of symptoms that might indicate a disorder. So at certain ages, kids are going to have imaginary playmates. Probably shouldn't have those imaginary playmates when you're 16. So trying to think about where someone is in the spectrum of different disorders has a lot to do with quality of life and functioning. And so we want to try to make sure that kids become healthy, happy adults. And so we have to watch their functioning to make sure they're on the right developmental trajectory to do so. One thing I do want to mention is you can have distress as a child and still end up being a perfectly happily functioning adult. But we want to make sure that we're doing everything we can to help kids along. So, the impact of values on definitions of these disorders is an important sort of side note, and I started wandering into this topic on the last slide. In statistical deviance definitions, we have to decide whether to examine sort of both extremes of a behavior. So, when we talked about emotion, probably lack of emotion is just as bad as too much emotion. Certainly, if we're talking about intelligence, very low intelligence is problematic, but certainly, now here's where we start to get into this question, is super high intelligence disordered? Well, we value intelligence in Western societies, and probably most societies, but that might lead to some disorders or might be indicative of deficits in other areas. So, for example, emotional intelligence is separate from crystallized or fluid intelligence. So we have to think about where we place our values in terms of these kinds of judgments. So in sociocultural definitions, value judgments are certainly very basis of different definitions of a disorder. So for example, what is a disordered use of a mind-altering substance? So might be very different. So Native American tribes are allowed to use peyote in some of their spiritual practices, but that would be considered possibly disordered in populations outside of those Native American populations. It would certainly be considered illegal. And the amount of alcohol somebody might consume is certainly going to be a sociocultural definition. In the Middle East, any alcohol use at all would be considered haram or against Islam. It would also be very different in terms of the amount you might drink and the time of day you might drink across Western cultures. So it's very common for Europeans to have a glass or two of wine with lunch, but very unusual for Americans to do so. Although in the 1950s, certainly the 3-martini lunch was the norm. So before I continue rambling on about that, let's move on to think about mental health definitions. Here we're talking about values of psychologists, psychiatrists, and clinical social workers. These are embedded in both scientific and lay community decision-making. We like to think of science as being outside of social cultural values, but it's not. It is embedded directly in our social cultural values. From the questions we ask to the way in which we ask them are embedded in those social cultural definitions. And you can certainly trace the research around sexual orientation, substance use, substance abuse, depression, hysteria is a great example, have differed over time. So hysteria is the sort of longest running mental health diagnosis. It literally means wandering uterus, as I recall. And so it is very sexist in nature. Goes back to ancient Egypt, as I recall, is when the sort of first use of the term seems to have arisen, and was basically applied only to women all the way up until Freud started examining hysteria. Still very sexist definitions. And we're going to talk in the next slide a little bit about some of the altering ways in which these definitions have applied. So the Diagnostic and Statistical Manual of Mental Disorders, we're on DSM-5 now, is developed by the American Psychiatric Association. And like all things in our world, it's written by committees and voted on. There are a lot of issues with the DSM. And one of the things I will say for my students is throughout the semester we're going to talk about the DSM, but we're not going to focus on it too greatly, because by the time you get a job somewhere, the DSM is going to change. But I want to talk about some illustrations of how the DSM has changed over time and how this is sociocultural. So in DSM-1, the very first DSM, homosexuality was classified directly as a mental disorder. So you could be, basically you could be institutionalized in a mental health hospital before being homosexual. One of the things you have to keep in mind is that psychologists and psychiatrists have the power to institutionalize people against their will in some instances. And so in this case, individuals could have been institutionalized, and this still happens with kids. Parents send them off to be institutionalized to cure their homosexuality. So this is still going on, which is a problem that we'll get into as we move along. DSM-2, homosexuality is removed as a mental disorder. It starts off as a paraphilia, and a paraphilia is just sort of unusual sexual interests. Then it's later pressings changes to sexual orientation disturbance. And the basic idea behind that is people are just disturbed by the fact that they're gay. And that gets us to DSM-3. In DSM-3, it's ego-dystonic homosexuality, which then becomes sexual disorder not otherwise specified. Basically, both of these are persistent distress regarding their sexual orientation. And so the diagnosis has to do with the distress about one's sexual orientation and not their sexual orientation themselves. Then 4 and 5, it's pretty much dropped altogether. There are some issues with 4 and 5 in transgender issues we'll get into later on. It's a clear example of how culture and values reflect what we consider to be a disorder. This recently has resurfaced in debates over reparative therapy. One of the things I will say, and we will discuss this semester, is reparative therapy is not therapy, it's child abuse. And that's very clear. And if you look at the data on reparative therapy, or I should say so-called reparative therapy, it's terrible, and the outcomes are terrible. And the American Psychiatric Association and the American Psychological Association have both banned its use. And a number of people have sued to try to get their licenses, even though they don't want to go along with that ban, with very little success. So one of the things I want to make very clear is this is an issue that we will get into. There are other examples, not just about sexual orientation, and I think this is an important one, and I've actually put the link here at the bottom. It's this really interesting article from The Atlantic on how Victorian women were oppressed through the use of psychiatry. And not just Victorian women, this continues through the 20th century as well, and probably arguably still goes on. But in the 19th and early 20th century, women were institutionalized at vast rates for doing things like, burning dinner. I don't mean to be flip about it, But literally, there are just egregious examples. So the Atlantic article starts off with a girl who is institutionalized for poisoning her father or stepfather who had been sexually abusing her. And all of the treatment of that case was one in which the press and everyone talked about what was wrong with the girl, not what was wrong with the man. Then this carries forth, essentially men were able to get their wives institutionalized. When they got tired of them, they would just have them institutionalized and then carry on with someone else. In the later 20th century, we see psychiatrists doling out Valium and other sedatives, black beauties, that sort of thing. No, that's not right. Anyway, sedatives. So sedative tranquilizers to, basically keep women docile and at home. And it's very clear. And in fact, that's what the Valley of the Dolls is about. So without wandering too off topic, I just want to say that the way in which we have used mental illness diagnosis has a pretty bad history. And so you're going to find that I have a skeptical view often of the overdiagnosis of mental illness. I think it's incredibly important that people with mental illness get treated, and being someone who suffers from anxiety and major depression, I think these are incredibly important issues to be addressed. But I also think we have to make sure we're doing it right. Anyway, let's continue on. So some definitions of psychopathology and developmental psychopathology, and here's where we start to get into some really dicey territory in terms of what is psychopathology. But generally, we're talking about intense, frequent, and or persistent maladaptive patterns of emotion, cognition, and behavior. So this is basically emotion, thoughts, and behavior. So intense, frequent, I think, are two important parts of this. So we want to make sure we're thinking about, it's okay to have intense emotions, intense thoughts, and even some intense behavior now and then. But is it frequent? Is it disrupting your life? And is it maladaptive? And that's another important part of this. And so we'll think about how emotional responses, thoughts, and behaviors are part of that. Developmental psychopathology then extends this to emphasize these maladaptive patterns occur in a different context of normal development and result in the current and potential impairment of infants, children, and adolescents. So we have to think about where someone is in their developmental timeline and make that judgment. It's easier with adults, ostensibly, because once you're 21-ish, we assume you've probably developed sufficiently to the point where you can start making some of your own decisions. And whereas with kids, we have to figure out where you are in that developmental timeline. And I would say when we talk about developmental psychopathology, this is going to include into the early 20s for some people. And so thinking about developmental timelines isn't about just children, infants, children, adolescents, but also teenagers and where they are. So one of the issues we get into is trying to study these issues and trying to understand how common or uncommon they are. This is an incredibly difficult task. We call this developmental epidemiology. It's a field that studies frequencies and patterns of distributions of disorders in infants, children, and adolescents. So we try to figure out how common major depressive disorder is. That's a problem because children oftentimes obviously can't speak for themselves. They aren't responding to research. Their parents have to do so, and parents oftentimes are reluctant to do so. So this can be really difficult. Oftentimes we have to rely on reports from schools, that sort of thing. So prevalence is just a term of art that refers to all cases of a disorder, whereas incident refers to new cases in a given time period. And so if there's an increase in the incidence of a disorder, that might be of particular interest. So we'll talk about that. It's estimated that about 13% of children between 8 and 15 years of age meet the criteria for some sort of mental disorder. These can range from dysthymia, so kind of a lower level form of depression, to major depressive disorder, conduct disorders, attention deficit hyperactivity disorder. All of these are things that we can get into throughout the term. So some final thoughts. One of the things we always have to think about with both children and adolescents, but I think children and adults, but particularly children, are some barriers to care. We know that kids who come from lower incomes, higher stress households are at higher risk for mental illness and mental disorders. So oftentimes those kids have difficulty getting into care. These are widespread. These include structural barriers, barriers related to perceptions about mental health difficulties, and perceptions about mental health services. Lots of stigmatization for parents. So shame, fear, blaming themselves. So they are reluctant to get their kids help because of that stigma. One of the things I want to emphasize about this particular issue, and I see this a lot, are attitudes from people my age. So I'm 50, or the generation beforehand, are, well, we just dealt with it, or even worse, we didn't get treated for this. We just got we got the belt. So basically saying people should just deal with it or tough it out, and that's how kids have always been. And that's a really disordered way of viewing this. One of the things I want to emphasize is just because people did it differently before doesn't mean we shouldn't be doing it. We should be doing it the same way, is what I should be saying. The most dangerous words we always hear, we've always done it this way. We used to treat people with leeches. We don't really do that much anymore. We used to not vaccinate our kids. We do that now. Kids live a lot longer. We're much more likely to make it to adulthood. We didn't used to give people antibiotics, but now we have a better understanding of mental disease and disorder, and we can actually create happier, healthier adults if we understand these issues and we treat them appropriately. Anyway, concluding thoughts in this first sort of topical lecture in childhood psychopathology, and I will see you next time.